So welcome everybody today to the Healthier Together Lunch and Learn session. On today's session, we're going to be covering sleep. My name's Laura Cassidy and I'm the Network Delivery Manager for the Child Health and Wellbeing Network for the North East and North Cumbria and lead on the Healthier Together website. And we've got Liz McClellan. If you'd like to introduce yourself, Liz.
Yeah, hi, my name's Liz. I'm a paediatric registrar and have a real interest in sleep, so here to share that with you today.
So just to give you some context and background with regards to Healthier Together. So the Healthier Together website is funded and led by the Child Health and Wellbeing Network for the North East North Cumbria. And the network was established in around 2018, and it was very much born out of working together with professionals from across the region and children and young people to understand what they would want the network to do as its function and what they wanted to achieve. And from these events, the vision of the network was born from that. And it's very much the vision is that in the North East and North Cumbria, we believe all children and young people should be given the opportunity to flourish and reach their potential and be advantaged by organisations working together. And actually, when we asked what they wanted us to do, it was very much about sharing good practice, drive work forward and connect to expert groups and experts. And actually, Healthier Together is one of those work streams which I think really shows how the sharing of good practice and actually experts and groups working together to deliver consistent health information and advice for children, young people and families across the region. As a network, we have priorities that were identified through this, and actually as a result of COVID, you can see the arrow there to family support, and we went back out to consult as a network. Family support was an additional priority added to the priorities at that time. And you can see the priorities down the side, and I think there'll be no kind of shock to anybody in relation to those priorities, because I think they're driven a lot of the priorities of what probably underpins a lot of our work within health, whether that's health, education, social care, or within community settings. So today we're going to be doing the Healthier Together Lunch and Learn session. I'm going to just give you a quick introduction of why Healthier Together, and then I'm going to hand you over to Liz McClellan, who's going to lead the session around sleep, children and young people, and then we'll finish off with a question and answer session. So why Healthier Together? I think we all know that for a lot of people, navigating health services can be quite complex. We have a lot of services that people need to access and not always sure when to access, where and how. And actually these arrows just replicate and show how complicated that can be, and actually how sometimes services can be cross-cutting, and actually sometimes there can be, waiting times, and how to navigate that sometimes from parents can be quite frustrating and quite challenging. And it's about how we give them the tools to really equip them to understand when and where to access services, and actually sometimes how they can self-care themselves. So why Healthier Together? Healthier Together was adopted by the ICS North East and North Cumbria Child Health and Wellbeing Network as a model of good practice, and it was developed in the Southampton region by a consultant paediatrician, and it was actually it's grown at pace massively nationally. The idea of Healthier Together is about having consistent health messages, but it's also about localising the information to ensure that locally parents and children and young people are able to navigate and be able to access the right services at the right time. We also know as a region that we have significantly higher rates of A&E attendances across all age ranges compared to the England average. So a lot of the work that we've done is around acute illness and about being able to understand when you need to be seen by a health professional and when you can self-care within the home. And actually the work that was done in Southampton's actually shown and had a proven reduction on unnecessary attendances at A&E. And actually a lot of the consultation with families and parents, actually they fed back that with the information they felt much more confident to be able to self-care at home for their child. Alongside the website, we've also got the Healthier Together mobile app, and that's very much similar in relation to the website. The website's much more broader in its content. However, the app's very much focused on that acute illness, and it's very much for when your child's unwell, what to do and how to really understand whether that is to get your child seen at A&E, but it's also and whether they need to be in within primary care. So the symptoms are very carefully selected in relation to which part of the system you would need to access. And it's actually about not delaying presentation, because I think sometimes parents can worry that they shouldn't go to A&E, or that they don't want to put pressure on the system, as we see all the challenges in the press. So it's very much about knowing that you've got the right information and that you're going to the right place. So its target audience as a website, Healthier Together, has a healthcare professionals section with standardised local clinical pathways that have been developed by our clinical group, led by our clinical leads and advisors and GP advisors from across the ICS. The site's very much for all age ranges, so it's got information and resources for pregnant women, parents, carers, young people, and has a dedicated young persons section. And the main aim of the website is really to promote that consistent advice aligned with information available on the parents' pages, and that facilitates that shared decision making. So it's very open and transparent, that parents can actually see the professional section, and actually the professional section links directly to the parent information as well, so that professionals can share pages directly with the website from the website's SMS sharing facility. So just a little takeaway from today with these slides, I will be sharing them. You can download the Healthier Together app from the App Store. You can have a look at the website and obviously familiarise yourself with that, and share and signpost or children, young people and families to the website within your practice. And we're really trying to encourage as well uptake of the Healthier Together app within primary care across the region. I've also just finished off, we will have a slide that I'll share for you to join the network if you haven't already. I'm just conscious we normally do this at the end because of the way the presentations are not joined together. We're doing it. I've just added it in there for information purposes only. I'm just going to stop sharing and I'm going to hand over to Liz to lead the session on sleep.
Thank you. I'm just going to load up my slides. Hopefully that will load shortly. Can you see those there, Laura?
Yeah, it's there. You sound a little bit quiet, Liz. I'm not sure if your volume's turned up.
I am, but I will see if I can do. Is that a bit better there?
Yeah, that's better.
I'll speak up. So
yeah, it is a little bit quiet.
Okay, so my name's Liz McClellan. As I said before, I'm a paediatric registrar working up here within the northern region, and have a specialist interest in paediatric respiratory medicine and in sleep. So before we start, I don't know if you've used Slido before, but if you've got a phone, you can scan the QR code, or you can just go on your web browser, go to slido.com and pop in that code there, and that's just going to make things a little bit more interactive as I go through my slides today. Don't worry if you've not got that down yet, it will pop up as we get to the bits that need it. So first of all, why me and why today? Well, I have been training as a paediatric registrar for a number of years now, and undertook a respiratory specialist interest module. And it was when I was doing that I actually discovered that I really enjoy thinking about sleep medicine and what it involves for children and kind of the wider community. It also turns out it's a personal interest of mine. And when I looked in my iPhone at my photos, I had more than 1,000 photos of my children sleeping. So clearly I'm as obsessed with it at work as I am at home. So first of all, just for you all to have a little think, just if you can just pop in using the Slido, what is sleep? What do you think makes up sleep? So this could be either a word or anything, or a statement. Why do we sleep? Perfect. So we can see, looking at this, there's lots of different things that it's important for. So it's essential, it's time, it's repairing and regenerating and processing. We're growing, our body's resting, we do it to survive, for self-care. All these different things that are all essential to why we need to sleep and what we're doing it for. It's there for nurture, for growth, and also for healing. And this is important not just for children, but for all of us. Storage of memories I can see in there as well. What else can I see? Okay, so the definition of sleep is perhaps not easy to actually define itself. Superficially, it's a simple and a passive process. We all do it, but actually sleep is a highly active and a complex state. And when trying to find an actual definition for what sleep is, there's various different ones that are bandied about. So we've got a reversible disengagement from and unresponsiveness to the external environment. Well, I think that does sum up what's happening, but perhaps not everything that's happening. So it's a naturally recurring state of mind, which is characterised by altered consciousness, relatively inhibited sensory activity, inhibition of nearly all voluntary muscles, and reduced interaction with surroundings. And I think both of these sum up different bits of what sleep is. But actually, if we wanted a simple one-sentence definition for what sleep is, I don't think that's easy to produce. Sleep relies on production, and your sleep-wake cycle relies on melatonin production, and this is inhibited by light, and it has kind of peak levels of concentration within the body, so lower levels within the morning, so that's seen on the graph at the bottom. So your melatonin levels fall to this normal daytime low, and then as you get towards the evening, your melatonin production increases and your levels peak in the middle of the night and then quickly drop until the morning. And melatonin is secreted from the brain. It responds and reacts to the amount of light that the eye is exposed to, and light-induced activation prevents the production of this. So this, we can see, can be where some of that interaction and that delaying of sleep and issues with sleep can come from. So just have a little think about how much sleep did you all get last night? Now, I know that last night might not have been your average Tuesday night, but just kind of where were you? How much did you get? For me, I didn't sleep very well last night. I was disturbed by several neighbours coming home in a taxi. I was disturbed then by my children, and actually I was a little bit nervous about today. So I particularly wasn't great on the amount of sleep that I had last night. Okay, so looking at that, the majority of us got between 6 to 8 hours sleep. There was about a quarter of us who had less than 6 hours sleep, and then somewhere in the middle, kind of with 8 to 10 hours sleep. But I guess the question is, did that sleep feel enough for you? Were you well rested? Do you feel like you had enough quality sleep last night? So your sleep. So for adults aged between 18 and 64 years, on average, the recommended amount of sleep would be between 7 and 9 hours, and that would fit with where lots of us were last night. Now, these are just recommended amounts, and it's not very easy to know how much each individual person is going to need. So if we look at this chart for newborns between 0 to 3 months of age, they need between 14 to 17 hours of sleep. Now, this isn't going to be as one discrete block, it's going to be as lots of little interrupted blocks of sleep. And as they grow older, the amount of sleep gradually decreases. They typically will still need a daytime nap up until toddler preschool age, and at some point they will then just consolidate to one longer overnight period of sleep. And if we look at this graph on the right hand side, so this was a study which looked at the amount of sleep that infants were getting, and the mean is shown by the dots. So if we look at this smallest baby, one of the smaller babies between 0 to 2 months, they were getting just over 16 hours sleep, but actually as their mean. But actually looking at the amount, so this ranged from up to 20 hours in a few occasions and down to 13 hours. And we can see that each individual person or infant had a different mean, but a huge variation in the range of sleep that they were needing on different days. And I think we know that most adults in the UK are chronically sleep deprived, and there's probably an element of children who are also chronically sleep deprived, but we just don't know the numbers, and it's not as easy to ascertain the numbers. But just to think about it, For every hour that you miss a night of sleep, that is missing one entire night's sleep per week. So sleep is important. And why is it important? Well, we know that sleep issues are increasing. A 2021 UK survey found that for 6 to 10-year-olds, on 3 or more consecutive nights the week before, they were having sleep issues, either getting to sleep, waking up in the night, or feeling not particularly well rested. And this was in 28.7 of 6 to 10-year-olds that were surveyed. And this figure increased. So for the 11 to 16-year-olds, 38.4% of those were having sleep issues. And sleep has a huge impact on our growth and development, but particularly on attention and short-term memory and consolidation of long-term memory, decision-making and reasoning. It's really important for those cognitive and neural pathways for all children that develop and consolidate while we're asleep. But it also has a significant role in almost every system within the body. We obviously know the link between mental health disorders and poor sleep and how that can exacerbate all sorts of things. But there's also a role in immunodeficiency, so in your innate and your passive immunity. Cytokines are produced when you're asleep and they help the body to fight infections. So if you're not sleeping as well and not producing those cytokines, you're relatively going to have an impaired immune function. We also know that for children who have vaccines and then poor night's sleep following this, they don't have as good vaccine responses as those who sleep more soundly. And there's been studies that have shown this. There's a link with cardiovascular heart disease, so with both pulmonary hypertension affecting the respiratory system, but particularly right ventricular hypertrophy affecting people later on in life. There's a link with obesity and the production and secretion of ghrelin and other hormones that are related to obesity. And we can all remember the next day when you're feeling tired, you just want to eat and sometimes just eat beige food. And that's linked to that. These cytokines that are produced overnight actually have a link to do with pain. And we can see that where people have had operations and then disturbed night's sleep, actually their pain response is not as good as those who've had better night's sleep. And there's also a link to diabetes and other hormone imbalances. There are significant increased risks in all of these systems if you have insufficient sleep. And this doesn't just affect children, it affects adults as well. So I thought we'd have a little think about 4 cases. So the first case is a 4-year-old boy who's falling asleep at school and mum's come to see you. So what do you want to think about in this 4-year-old boy? What particular things do you want to be asking or looking at? So we can see there's lots of
doesn't go on.
lots of,
No, coming up on there, look. Unless it's.
oh, sorry, can I just ask everyone to mute, please? Is that all right? So lots of people are thinking about bedtime routine, thinking about exercise, what time they're going to sleep, the environment that they're going to sleep, changes within the home, thinking about their day-to-day activities, whether there's other things, thinking about screen time. So there's lots of different things that we need to be thinking about for this patient. Thinking about presentation at school, what do they look like when they get to school? So there's lots of different things. So one of the tools that is out there that was developed in 2005 is the BEARS sleep screening. So this is a developmentally appropriate trigger questions. So B standing for bedtime problems, E for excessive daytime sleepiness, A for awakenings during the night, R for regularity and duration of sleep, and S for snoring. And there's different questions that you can ask to the parent and the carer. And this, if you just do a quick Google search, you can get the BEARS sleep screening tool and it comes up. So just thinking about, do they have any problems going to bed and falling asleep? And then thinking about all those things that we've asked about just before. Do they have a regular bedtime and wake time? What are they? Do they snore? Do they seem to have any breathing difficulties? And these can be asked either to the child or to the carer if the child is struggling to answer. So going back and thinking about our case, so it was a fight to get him to bed. He's 4 years old, but he's got older siblings and they were going to bed later than him, and he wanted to stay up. And in the morning, when it was time to get up for school, he was tired and grumpy and was having naps at weekends and would often fall asleep in the car as they were going on longer journeys. Then there were no issues once he was asleep. He was soundly asleep and not waking up, and he was quiet when he was asleep. And his regular routine was just that he would go to bed at 8:30 and wake up at 6:30 in the morning, and that was 10 hours. But at the weekend, he was going to bed later and would sleep in later if he could. So we talked to the parents about the bedtime and the nighttime behaviour and about all those things, the importance of having a regular routine and the importance for your body clock of going to bed at the same time and getting up at a similar time each morning, so within a 2-hour window, just to help your body clock stay regulated. Thinking about what you do in the time before you go to bed. How did you signal it was bedtime to this child? All of a sudden, were they stopped watching their favourite TV programme and just told it's bedtime? Or actually, did they have the same thing that they did each night, whether that was a bath or a story, or which way they had to relax this child? Thinking about the environment that the child was going to bed in. Is it warm? Do they have the right amount of noise? And some children like noise, some children like total silence. Some children like lights on and some children like complete darkness. Thinking about exercise, so are they getting exercise in the morning where the light can stimulate the circadian rhythm, and think about the effect of getting morning exercise and fresh air. Thinking about food and drink and not taking those just before bed. And then thinking about, do they have self-settling behaviours, or did they want the parent or carer to be there with them when they were going to bed? We've got lots of resources available for this. So on the Healthier Together webpage, we've developed sleep pages. So the sleep advice for different age groups. We've got one for toddlers aged between 1 to 4, one for younger babies, and one for primary school age children, and again for older teenagers. And all these resources can be sent directly to the parent. If you just put in their mobile numbers at the top, they can be sent the link directly to the website. We also have parent and carer information that we've developed that are on the website as well. And these are just to give to the parents. So talking about all these things that can be important to help them settle and get into a regular routine. And actually for this child, some simple sleep hygiene changes and actually signalling to the child what time bedtime was and how the routine was going to change actually resolved the symptoms, and it was relatively straightforward. But for ongoing issues, we know that there's more information there on the Healthier Together webpage. They might need further input from the health visitor for review, and just further going and sitting down with the parents and talking about how they can make this routine better for their child. There's also a South Tees scheme that I'm going to talk to you about a little bit later in the presentation, which is looking particularly into behavioural interventions that can be made to help improve children's sleep. And the other thing just to highlight is about bed poverty. So bed poverty is where children don't have their own bed to sleep in. So they may be sleeping on a sofa, they may be sharing beds with their siblings or with their parents. And this is for families who haven't particularly made that choice, but just don't have the money or the funds to buy a bed for each individual child. And one of the studies in 2017 by Buttle showed that 27% of children in low-income families don't have a bed to sleep in. And at that point, that equated to 400,000 children in the UK were living with bed poverty. And I suspect with the cost of living crisis, that may even have gone up now. And we know that there's a huge link between a lack of bed and poor sleep, and this can have a direct effect on the health, mental health, but also education. And this has recently been debated in Parliament in December last year. And there's a plan, hopefully, to create a national sleep strategy to help end this child bed poverty. But it's a real issue, and it's a real issue in our region. There's several charities in the northeast that are working to help support these families. And these are just a few that I found when I did a Google search, just to find different ones that there are out there for different areas. And again, these are supporting families either to buy beds or to buy furniture or to buy clean bed furniture, so or sheets and duvets and things like that. Okay, so moving on to case 2. So case 2 is a 7-year-old boy, and he has presented because he is snoring. It's a relatively new problem, but it seems to be getting worse. So what would you want to know for this? So again, there's lots of different things that people are thinking about. Are they having apneas? Are they having pauses in their breathing overnight? What's the child's weight and activity? Are they doing things in the daytime? Are they obese? Are they underweight? What daytime behaviour have they got? So are they tired in the daytime? Are they snoring during the daytime? Do they have other issues? So do they have Down syndrome? Do they have other ENT issues? Are they having other problems with nightmares? Are there any allergies that are going on? So are they having problems with sniffing or with stuffy noses as well? So lots of different things to think about. Is the child waking themselves up? How are they positioned in bed? Are they lying on a pillow? Are they on too many pillows? So snoring is really common, but it can be difficult to work out, is this just primary snoring and just a little bit of noise? Or actually, is this something more serious like obstructive sleep apnea? Things to think about are whether they're having any nocturnal symptoms. So as you rightly said, are they snoring? Are they having pauses in their breathing? Do they look uncomfortable in bed? Are they waking themselves up with their snoring? Can you hear their snoring from downstairs when they're upstairs? And what daytime symptoms is the child having? Are they tired? Are they groggy in the mornings? Are they complaining of any headaches? Again, issues that can be linked with obstruction. And actually nowadays, lots of parents have mobile phones and can video their child. And we can see on this child, they're snoring, they're having pauses, they're disturbing their sleep. But we can also see that they're breathing and their chest and their abdomen are moving at different times. So risk factors for obstructive sleep apnea are your sleep state. So in specific parts of your sleep, you are more likely to relax and to develop more snoring. Is there any airway narrowing? So do they have an underlying anatomical variation in that specific airway that might be all the way from the nose further down that may just cause them to be more at risk of obstruction? Do they have increased tissue around the airway? So that might be something like adenotonsillar hypertrophy, so where you've got those big adenoids and the big tonsils, and they typically might develop around 3 or 4 years of age. Do they have any excess adipose tissue? So is the child obese? Do they have excess tissue around the neck, which would then lead to issues with obstruction? And again, thinking about abnormal muscle tone. So do they have something underlying like trisomy 21 or cerebral palsy, where their muscles may relax more than others, and this can lead to obstruction and further need for involvement? There's lots of things to look out for on the examination, and I guess the real important things are to see, actually, can you see any tonsils that are there, because that's going to work out where they're going to be referred to. Are there any other issues that you might be able to see? So are they obese, or do they have a failure to gain weight? Are they mouth breathing even just at rest? They may have this pectus excavatum, where you can see the chest deformity as a result and as a complication of their obstruction. And again, thinking about their tone and their developmental status. So we can do overnight oximetry, and this is a relatively simple test that is available through lots of the different DGHs that we can organise. And it looks at their oxygen saturation levels over a night period, and it records this and gives you a trace, as you can see on the screen. So oxygen saturations at the top, heart rate at the bottom, and then the progress in time over the night. And you can see, looking at this trace here, there's lots of clusters of desaturations, and these desaturations are going down to the 60s at times and the 70s. So significant clusters of obstruction that's occurring for this child. And we can move on if things are not as obvious to do further sleep studies, looking again at desaturations. And this is a 3-minute period from a nighttime recording, which shows 7 episodes of desaturation. And when we look at it further, we can see that there's obstruction that's occurring. So obstruction, for whatever reason, is causing this sleep apnea and needs intervention. So the child that I talked about, the 7-year-old, had an adenotonsillectomy, and the oximetry, the oxygen saturations, were used to work out whether we needed to keep them in overnight after their operation, or whether they could simply go home and just have a repeat set. We don't need to do repeat oxygen levels for all patients, but in some that have been particularly significant before they have their adenoids and tonsils removed, we repeat them after 6 weeks to make sure that there has been an improvement. And if there was no improvement at that point in time, then we would have another little think about what we might need to do, whether that would be to do a sleep study at this point, to address any other potential causes, talking to parents and the child if there's any obesity or any other things that are potentially reversible factors. And they might need to be re-referred back into the ENT or respiratory clinic to have a think in more detail and see if they need any further support and intervention. Okay. So we'll move on to case 3. So case 3 is a 5-week-old baby who's got faltering growth and noisy breathing. So what would you want to know in this case? Perfect. So lots of people asking about feeding. So are they breastfeeding? Are they bottle feeding? What has been tried to support that feeding, that feeding patterns, and how are they doing? Thinking about looking back to the birth, were they born early? Any issues around the birth itself and complications? Thinking about their position when they're asleep. Is the baby sleeping on their back? Do they bend their neck, or do they sleep with their chin tucked down on their chest? Have a think about their sleeping as well. Is their sleep noisy? Are they noisy during the day or noisy at night? We've got people saying about bronchiolitis, so thinking about, is there something else that's going on top of this that's causing this problem? Thinking about cardiac issues, is there a problem, you know, any issues with the heart or any murmurs to listen for when you're looking at them? Do they have anything like a tongue tie, which could be a simple, a potential reason as to why they're not feeding very well? Do they have any issues with their larynx? So are they noisy? What does that noisiness mean? And what are they like during the day? So yeah, lots of different things to think about there. So when they were seen at the GP, the noise was worse when they were asleep, but actually, given that they were only little, they were only 5 weeks old, they were asleep quite a lot of the time. And the noise was an expiratory noise, so a noise as they were breathing out, and it was a low pitch rumbling noise is how I would describe it. So different to the high pitched squeak that you get with stridor and laryngomalacia. The baby had been born on the 9th centile, and there was a feeding plan in place. They were breastfeeding, but had lots of interventions and support with that, and were still not gaining weight. So they were having breastfeeds and top-ups, and mum was expressing milk and getting good volumes of milk. But despite all this, the baby's weight had gone from being on the 9th centile at birth to being on the 2nd, and was actually still trending downwards. And the reason the mum went to the general practitioner was the baby was now having pauses in their breathing, and she was worried that they were stopping breathing. So the baby was referred to see us at the RVI just because that was their local hospital. They were admitted overnight, and we did overnight oximetry. So we did our overnight recording of their saturations. And when we did this, the nurses document their routine observations as well. And the saturations look reasonable, although slightly low in the low 90s. But it was only when we looked at the overnight oximetry we could see that the baby was having real dips, and dips quite frequently down into the 80s, but also down into the 70s. And they were having colour changes as well that were being noticed. And they were reviewed by the ear, nose and throat team the next day, who were able to do a flexible nasoendoscopy. So this is where they take a small camera, pop it down the nostrils, and then they're able to have a look with the baby awake at their larynx and their voice box, and excuse me, to look at the top part of their airways to see if there was anything on there that would explain why this baby had this noisy breathing and why they were having these difficulties with feeding. So with a jaw thrust, everything looked nice and normal. There was nothing you could see that would explain things. But as soon as that jaw thrust was let go, everything collapsed down, and the baby had a very floppy pharynx that was just collapsing towards the top of the windpipe. And there was lots of crowding in there. So they were initially trialled with some oxygen, so just high flow oxygen in air, and their oximetry improved. And we gave them a period of stability and time for them to feed and grow. And it was thought that this was all just floppiness of that upper airway that was causing the problem. And by using the oxygen, we could promote them their growth and stabilize things for them. We actually took things back with the feeding, and actually once they were able to breathe and this high flow was stenting the airway, then actually they didn't need to use as much effort for their breathing. So it meant that they could use their calories to grow rather than using them to breathe. And they were discharged home with high flow and ongoing respiratory input. Okay, so final case. This is a 14-year-old girl who is tired all the time. So what would you want to know for this teenager? Perfect. So there's a lot of people thinking about sleep routine and bedtime routine. There's thinking about lifestyle and what's going on around that, thinking about the menstrual cycle and periods, and also thinking about screen use and mental health issues, social media, thinking about worries, anxiety, thinking about what time bedtime is, thinking about their emotional well-being and relationships and kind of what's going on. So there's a huge amount of things to think about for someone of this age who's presenting at this point in time. Are they having school issues? Are they having issues and worries at home? What are they thinking in terms of their eating times and their exercise as well? Thinking about, are they sharing a bedtime? Thinking about relationships and what's going on there, and thinking about school issues. Okay, so the bedtime for this child, she was going up to bed about 11:30, but actually really struggling to get to sleep, and was on her phone looking at Snapchat, looking at social media. And it happened that she presented actually during the pandemic, so she wasn't actually in school at this period of time, but she was going to sleep actually about 2:30 in the morning. She was having to get up on weekdays at about 9 o'clock to log in to do her online lessons, but at weekends she'd be sleeping in till about 12:30, 1 o'clock. Her phone use was described as being excessive. She said that actually she didn't want to use her phone, but when she couldn't sleep, she'd go on there and she'd be messaging, or she'd be looking at things or watching videos to try and help her to get to sleep. So actually, we realised that there was a huge problem with the way she'd shifted her body clock. So we did some basic things. So did a sleep diary for her to look at when she was going to sleep, when she was going to bed. And this is a simple thing that you can get teenagers or parents to do, and think about what times they're going to bed, what time they're going to sleep, what times they're waking up in the day, and just thinking about when they're eating and when they're exercising, just to break it down for them. We can also do something like actigraphy. So actigraphy is a small, like a smartwatch really, that is worn on the wrist. and just detects movement. And we can use that to work out where they're up to and what they've been doing and what times they've been getting up and going to bed, and just have a little look in more detail. And actually lots of our smartwatches nowadays can give us a lot of this data. Our phones can tell us what time we're putting them down and going to sleep and what time we're picking them up again in the morning. So mobile phones and our normal smartwatches actually can have a lot of this information. So she had delayed sleep-wake phase disorder. So this is relatively something we see in about 7 to 16% of teenagers. It typically develops in teenagers, and symptoms can include a delayed sleep pattern, trouble falling asleep, an inability to wake up in the morning, and then actually they have a normal duration and quality of sleep when they don't need to go to sleep or wake up at a specific time. And essentially what's happening is they're shifting what time they're going to bed and what time they're going to sleep. And we typically often see it during school holidays, or we saw quite a bit of it around COVID, where people were staying up later and then didn't need to particularly get up to go to school the next day. And it needs to have lasted at least 7 days. So the basic treatment is, again, going back to basics. So going back to thinking about routine, thinking about exercise, getting exercise in the morning, not exercising too close to when you go to bed, thinking about food, not eating just before you go to bed, thinking about what drinks they're having, and most especially thinking about caffeine in this age group. So energy drinks, coffee, chocolate and tea, and just the talking to them about the interaction that can have on their sleep. For teenagers, it's a specific thing to mention and talk about technology, so not using screens within that hour just before they're going to bed, just to give themselves a chance to switch off. If they can not have their phones next to the bed on the bedside table, so they're not tempted to pick it up and reach out for it if they're not able to drop off to sleep. And again, making sure that you're talking to them and thinking about any worries or anxiety that they might have and helping support them with this. And again, we've got this information on the Healthier Together website. We've also got sleep leaflets for older teenage children as well available on there. For this girl, we actually treated her with some melatonin and a strategically timed low dose, which helped regulate her sleep-wake cycle, started at a dose of 2 milligram 1 hour prior to the time she was going to sleep. So where she was going to sleep at 2:30 in the morning, we'd start that about 1:30 in the morning, and then we gradually brought her bedtime forward. So gradually bringing that dose of melatonin forward. But this was done in real strict conjunction with hygiene measures and making sure that she was working through and kind of conforming with those sleep hygiene things that we know can help. There are pitfalls and issues with treating this. So engagement, you obviously have to have the person's real engagement in trying to make this better. And I know in some cases, actually, some of the centres around the country ended up admitting people for delayed sleep-wake phase disorder just to try and get things sorted for them, and were successful. We also know there's some issues with melatonin. It's currently on a shared care prescription and needs to be initiated by secondary care. And also to make sure that you're breaking it off. So having a break off it for 7 to 14 days every 6 months. And if it's not working, then they just need to stop the melatonin. So now we'll just have a little think about what services we've got available in the North East for paediatric sleep. So most centres will have someone within their general paediatric department who has a specialist interest in respiratory. And lots of these people might pick up some and have the referrals sent through to them for specific sleep issues. There is the paediatric respiratory team at the Great North Children's Hospital, and they are able to see urgent referrals and organise urgent reviews after discussion or referrals have come through. There is a sleep clinic that's a tertiary referral clinic that runs once a month with members of the multidisciplinary team. So they have access to the paediatric respiratory consultants, access to an adult neurologist, access to respiratory physiologists and further people who can help support and organise further investigations. Down at the south of the region in James Cook, Ahmed Hagab works and has direct involvement along with the long-term ventilation team. and he accepts referrals from GPs and secondary consultant colleagues, and he has access to sleep studies. So they do sleep studies down at James Cook over a weekend and have a team down there who analyse them. So we've got a regional service there. Basic investigations, as we talked about, are the oximetry, which tends to be done overnight or can be done daytime in newborn babies because they sleep as much in the day and night. It captures data every 4 seconds and means that we can have a look what's going on and see what trends are going on. But it doesn't tell us about why things are happening. It just tells us if there are desaturations happening and if there's any restlessness or any variations within the heart rate that's going on. And we use these fairly frequently, and they can be done at home relatively simply, just like you would put, an oxygen saturation probe and then downloaded by the various teams. We have access to sleep studies that, as I said, can be done either at the Great North Children's Hospital or down at James Cook. We have lots of different parameters that we can look at, and we can do further more detailed studies looking at brain waves and leg movements and muscles, as well for other non-respiratory conditions and thinking about things such as narcolepsy. And again, we use the whole MDT team to think about these cases. And these are just some of the sleep studies, just a couple of examples. The one in yellow is a normal sleep study, so showing lots of normal breath patterns between the chest and the abdomen bands and no desaturations on that. And the one at the bottom is showing lots of desaturations that are occurring over this 3-minute period. And this one is linked to primary central apneas, so where the baby is just stopping breathing, and they would need further investigation and thought into what is going on for this child. When I was doing my research for presenting today, I spoke with the team down at the Tees Valley Sleep Service. So this is a new sleep service that's been developed, and there are practitioners from teams within the health visiting, school nursing and family support service who at Daisy Chain who have had Sleep Scotland training. So the practitioners have been trained in delivery of sleep interventions, and they have this available to children between the ages of 2.5 and 18 years who has an additional health or development need. Now, they don't need a formal diagnosis for this, but and can be referred by various team members, but just someone who it's affecting them, their health or their development, can be referred into their system. And they've got a website that you can link into. So they have a 3-tier pathway. So tier 1, they provide telephone support and provide resources. So they have advice and guidance that is sent out and can think about sleep hygiene, and then parents can ring back after a few weeks to say how things are going. And if things haven't improved, then the practitioners can refer them to tier 2, which is where there's parent or carer workshops. So these have been done face-to-face, but they're going to look at potentially doing these virtually and online as well. And this can be have up to 10 families at a time, and is delivered between the family support service and the health visiting team. And again, they cover sleep hygiene and discuss about sleep diaries. They have then the opportunity to have nurse-led telephone support to implement the advice and guidance and make this personalised to the family. And then if they've still been fully engaged in the interventions and it's still not made any difference, then they can refer through to tier 3. And this is where they have a bespoke sleep plan, which is agreed one-to-one with a sleep counsellor. And then they have specific support during the implementation of the sleep assessment. So they're looking further to get feedback from families on the service. They're in discussions with the acute trusts locally to agree trust links to trust services. So for children who have an associated medical need, to ensure that they're kind of kept within the right teams. And they have a monthly steering group, so they monitor the service. They're looking into their spend on melatonin prescribing across the Tees Valley, and they're also agreeing a pathway for children for melatonin reviews, so that these children can be fed back into their sleep service to improve sleep hygiene alongside the medication that they're using. And they're very happy for people to refer into them or to seek further information if that's your local area. So, this is just a list of resources that I have used to make this. So there's lots of things, as I've talked about, on the Healthier Together website. We're in the process of updating some of our web pages and adding in a snoring web page. We've got information from the Sleep Charity and BASIS, which is the baby sleep information service run through Durham University, which has got lots of information for infants on there and lots of workshops and leaflets as well. This is the link to the BEARS screening tool, but actually it's probably easier just to Google it and find it. And a lot of the information about bed poverty I got from the Zarak charity, which is down in Leeds, and was one of the first charities to be set up to combat this. There's lots of different apps that are available, so families can be signposted. A lot of these aren't necessarily tested on children, but there's guided meditation or Headspace and Sleepio, and they could be useful for adults and children alike, just to have a little think about what's happening to our sleep and where we're up to with that. And there's lots of information on the Healthier Together webpage. And as I said, if you click on this yellow box at the top, you can then send the page directly to a mobile phone with the family's permission. So it'll send them the exact link to whichever web page you're on, and that'll go straight to their mobile phone. And you can send that to more than one family. And I found that particularly useful. And this is just our sleep information that we've got for teenagers that are on there as well, and useful resources. And finally, just to go back to thinking about our own sleep. So just to remind you, most adults in the UK are chronically sleep deprived. I guess we can all take a leaf out of the children's book and think about our sleep hygiene, think about our electronic devices use, and just think about the amount of sleep we're getting and the quality of our sleep, and what we can do to improve that. Thank you for listening. Does anyone have any questions? Oh, I'll stop sharing.
Just if anybody wants to ask a question, if you want to raise your hand.
Jan, I can see you've got your hand up there.
Who? Sorry. Jan? Sorry, my computer went on a go slow there.
Yeah,
Oh,
we
we can't.
unmute.
Oh, we can hear you now. We can hear you, Jan.
Can you hear us? Okay.
Yeah.
It's a question for Liz. Liz, we are Matrix Neurological, and we support children and young people and their families who are living with the effects of an acquired brain injury. Now, we know that these children often have problems with hormone release. They don't naturally produce melatonin. A lot of the kids we work with don't wake up just as tired as when they went to bed, and they've slept for something like 12 to 14 hours sometimes. And it's because they are not getting good quality REM sleep. So what would your recommendations be for us as to who to send them to?
I think a lot of these children would come through our community services. So our child development team seems to be where they come through and then come through to us. They could come in through secondary care and then for other things kind of then go on from there. But yeah, it's difficult, and we know that this is a group that has a huge amount of sleep issues.
Yeah. Okay. Yeah, because obviously parents are coming to us desperate for help, and the kids as well. So it's interesting for us. It's very medical, this presentation, but we came along to see if we could pick up any tips. But actually, considering the NHS misses 90% of brain injuries in children with mild to moderate brain injuries, you only ever really see those with severe, which are very limited. But I mean, this is now affecting 1 in 6 children in every class in every school across the UK. So this is a massive issue, but brain injury is never addressed anywhere. And daisy chain, for example, have turned brain injury families away because they deal with neurodiverse or neurodevelopment problems, of which brain injury isn't included, and nor should it be, because it's something very different. It's not the same as autism. It's not the same as fetal alcohol syndrome.
We just don't have the resources there for everyone to do it in a minute.
Mm. But actually, they're the biggest group.
Well, I can certainly raise it with the sleep team and think about things going forwards about how we can address that. Yeah.
Yeah. Okay. Thank you.
Thanks for coming. Caroline. Oh, sorry.
Hi, thanks. So I work in the weight management clinic at Leeds Children's Hospitals. A lot of our children obviously have sleep issues, which contributes to their weight, and then obviously their weight can cause problems with their sleep. We can do get our community nurses to do sleep studies, and we can obviously get Sentex done at the hospital. And we give out sort of sleep hygiene information and advice. The team, particularly our dietitian, are excellent at doing that. But we have a lot of families with children with special needs, autism in particular. And again, sleep can often be a problem. And for a lot of these young people, I do wonder whether melatonin would be helpful. The difficulty is they're often not under anybody. They're not under community peds anymore. They're not under CAMHS will maybe see them and diagnose them and discharge them. It's not obviously something that is particularly part of my training as a paediatric endocrinologist, and obviously the GPs can't then prescribe. So I just wondered if you had any ideas or suggestions about how to sort of think about tackling that, either at the ICS level or you know, I know they're trying to set up sort of sleep clinics at Leeds, and I know that they're trying to sort of get that underway, but I'm not exactly sure where things are up to.
I think you're right, it is a massive problem, and it's something that we see so I'm working in the RVI in Newcastle at the moment, and we see it as a massive issue as well, with people not necessarily being comfortable. I know that, for instance, some of our general paediatricians have ended up initiating melatonin, or some of our paediatricians have kind of given advice and guidance if they're, have the appropriate skills to do that. But I think you're right, it's really hard because it affects so many different teams from so many different kind of different specialities. I think a sleep clinic would be amazing, but it's just getting the funding for that, and that would be my dream and my ideal, but I just think it's not quite there yet, and actually they're not going to give the funding for that at the minute. Yeah, so I don't have a straight answer for where we can go with that. There is a lot of guidance out there for the prescription of melatonin. There are so kind of lots of steering groups that have produced guidance. We have one locally, and I know there's some down kind of in London as well that are available, but whether you have anything locally as well, for whether that's come out from your respiratory team or your neurodevelopment community colleagues, there might be something there that they could share with you.
I think that'd be useful, obviously, if there isn't a dedicated service, to at least have some more training so that the team would feel more comfortable in prescribing melatonin themselves. Because I think a lot of times we feel like we're telling these families to go away and access things that they just can't access, and that's not just with sleep, it's with CAMHS, it's with access to healthy spaces, etc. But obviously that's something potentially we could look at. Thank you, that's useful.
Thank you. Jen, I'm not sure if that was a legacy hand or whether you've put your hand up again. No, okay. Right, well, thank you. I'm just conscious of time. Thank you very much to Liz for your presentation today. I found it very informative myself. And thank you everybody for attendance. The slides will be shared, and the video of the presentation will also be hosted on the Healthier Together website. That may take a day or so to be added, but we will share the link with you once that's added as well, alongside the presentations. Thank you.
Thank you.
Thank you.